Okay, so thanks everybody for doing that rapid fire acquisition of food. And I am delighted to introduce David Myers, who not only is a fabulous charter, but he does a few other things. So he's the Chief Medical Officer for AHRQ, and he's been a critical piece of the strategic planning around the learning health systems work. And he's going to introduce us to a rapid fire exposure to some AHRQ exemplars. So to you, David.
Thank you so much, Beth. So everybody, what we're hoping you will do now is eat slowly, but listen quickly, okay? Because this is going, as Beth just said, is going to be rapid fire. And I want to put this a little bit of in context. At the summit in September, we had a sort of funnel approach. We started from the theory of the learning health system, as you heard. Then we got down to some of the practicalities, and that was Mary and Lucy's session. And then we wanted people in the afternoon to spend time coming up with those great examples you saw. But to get them from the theory and the practice and thinking about what AHRQ can do, we realized that while we did have some NAC members and some friends of AHRQ with us, we had many people who were new to AHRQ. We really did try to have a broad range of stakeholders, and we thought it was very important to give them some ideas about what is AHRQ, what do we do, what are some of our capabilities. So what you're about to hear are not exactly just exemplars. They all are, and the staff who are presenting them also deserve that title. These are programs we are all very proud of, but they were put together with a different purpose. We did this in a co-creation way. We asked AHRQ staff as a whole to think about what are we doing already that are contributing in some way to what learning health systems will need. These are not the programs that we design necessarily to move learning health systems forward. Were picked as examples that give you the sweep of AHRQ's breadth. And we did this, each of these folks presented 6 times to 6 different groups in a rotating fashion. So everybody was in a small group where they heard all 6. These folks were phenomenal. The good news for them is they only have to do it once for you today. At the summit, we asked people, we reserved a few minutes for questions after each one, and then there was a bell and they moved on. And the questions needed to be about how this work related to the concept of AHRQ and learning health systems. For you all, that's not as important anymore. The reason we want, and the reason is we brought this after the session. Several people came up to us, including some people here in the room today, and said, oh my gosh, I didn't know AHRQ did that. And if you all don't know all of what we do, we have a problem, so we're going to resolve that today. As ambassadors of AHRQ, moving out in the world, some of you now leaving us and going forward, and others who will be with us, we thought it was critical that you also shared this common framework of examples of the great work AHRQ is doing. So when they're done with their presentations, each should be about 5 minutes, we'll have 2 or 3 minutes left for questions on each one. Feel free to ask them anything you need to know to be a better ambassador for AHRQ. Does that make sense? So that's our goal. Again, in advance, I want to thank these 6 folks. Here they are and where they're from and the programs, but they're going to introduce them to you. Any questions? Make sense? Okay, so there's going to be do we have the cowbell? Okay. Right, we borrowed a cowbell to keep ourselves on things. So Ed, would you start us off? Do you want it in here? No, stand, yeah.
Thank you.
Thank you.
So I'm looking at Jamie because she was very strict about when to start it. Okay. Okay. Well, thank you, David. Thank you to the NAC for the opportunity to speak with you. My name is Ed Lomatin, and I'm here to tell you about CDS Connect. CDS stands for Clinical Decision Support. But before I dive into the program details, I wanted to say a few things up front, if I may, relative to AHRQ and the discussion around learning healthcare systems. First, CDS Connect is all about cutting-edge digital infrastructure for sharing clinical decision support and about helping learning healthcare systems advance evidence into practice. And I know that's abstract. I'm going to go into more detail. But the point I wanted to make up front is that this is as much about a digital platform as it is about the content. Second, CDS Connect is a new program for AHRQ where we've just begun our 2nd year. I'm describing to you prototype infrastructure for how learning healthcare systems could potentially use this infrastructure now and in the future. Lastly, I want to please ask you to think about CDS in very broad terms. Some CDS is not really an app or a widget, and it's really a process that weaves together people and technology to deliver what some may know as the 5 rights of CDS, right? This is to deliver the right information to the right people using the right technology and the right format at the right time during workflow to improve the quality of care. So at the end of the day, CDS can take the form of familiar, say, alerts and reminders, which are not always welcomed, but it can take more innovative forms such as dashboards, shared decision-making tools. And the audience for these tools isn't just physicians. It can be other members of the care team as well as patients and families. So for learning health systems that are trying to advance evidence into practice, think of CDS as a suite of things to help them do that, and think of CDS Connect as this digital infrastructure to help support the process. In fact, CDS Connect has 2 primary goals. One is to advance evidence into practice through decision support, and the second is to make CDS more shareable, standards-based, and publicly available. As a proof of concept, in the first year of the project, we focused on cholesterol management. So we translated guideline recommendations from the American College of Cardiology and the American Heart Association, as well as the Preventive Services Task Force, around the use of statins for the primary prevention of cardiovascular disease. And we translated those into interoperable, standards-based, what we call artifacts, computer interpretable clinical decision support. In our case, we implemented this as a screen or a tab that the clinician used in their EHR to help them have a conversation with their patients about their cardiovascular risk and whether taking a statin was appropriate for them. The CDS that we developed is posted in a shareable form, ready for local implementation and adaptation on this new publicly available infrastructure we call CDS Connect. The idea is that if you are a healthcare practice, whether you are a learning health system or perhaps on your way to becoming one, and you're interested in improving the heart health of your patients and cholesterol management, you don't have to start from scratch. If you're planning to use your EHR to facilitate evidence-based care, you can go to CDS Connect and find standards-based CDS resources or artifacts developed elsewhere, in this case AHRQ, and guidance about how to use them. The part about guidance is an important one. Remember, CDS isn't really about plug-and-play widgets. It's about advancing evidence into practice and improving quality. It's about knowing your staff. It's about knowing your patients, your workflow, and where technology can help. So the CDS Connect platform is about sharing how the CDS was developed, tested, and implemented. And so in our case, we partnered with a community health center, piloted the CDS based on the task force recommendations, and we're exposing as much as we can about how we actually did what we did, including all the assumptions we made from going from the guidelines to writing the computer code to what clinicians and patients actually saw during their visit on the computer screen at the community health center. This will help others decide what's appropriate for their own setting and how much adaptation might be required for their own implementation. Another exciting part of CDS Connect is a CDS authoring tool. So there are now international standards that describe the language of clinical decision support and how it should be specified. We've built an authoring tool so that others can use this CDS standard language to, again, make it easier for others to use and reuse. Ultimately, we think that decision support and digital infrastructure for sharing decision support will help practices and systems learn from each other and move evidence into practice more efficiently. Thank you. Questions? So I have questions. Anne.
And what that means is the questions should be quick so he has more time to answer.
So we did that same thing as probably 1,000 other systems did across the country. How can people share what they've developed into this system? Is there a way that it can be bidirectional? I mean, AHRQ's developing some, but is there a way that systems can go in and share, assuming it's not a proprietary tool they've created?
No, absolutely. So remember, there are 2 tools. The repository is meant to be public infrastructure for contributing and for using. So we've populated that repository with stuff that we've developed in the first year. And the first year it was based on, the use case was cholesterol management, where we're absolutely building the repository so that others can contribute it and share it. We've built tools such as APIs so that folks can automate some of that interaction with the repository. And again, the authoring tool, which it's just sort of a shameless plug, but if you're planning to stick around for AMIA, we're going to demo the tool and have a panel on it. It's going to be, and we're planning to release it as open source. And so we hope everyone will use it.
The other thing is this will really help in those NIH applications, how you're going to share what you develop with the public, so.
Okay.
It's because you were so clear. Thank you.
Thank you.
That was great.
So good afternoon, folks. My name is Herb Wong, and I'm happy to be here to describe to you the Comparative Health Systems Performance Initiative, a project that contributes to AHRQ's focus on learning health systems. So when you hear the term health systems, some long-term health systems might come to mind. Kaiser and Intermountain Health, for example, both have a long tradition with a reputation for efficient, high-quality healthcare. But what are the factors for this positive reputation? How well do they perform? Are their performance simply related to the fact that they are health systems, or are other factors in fact involved? Now, over time, the number of health systems has increased significantly, and today there are over 600 health systems. Now, given the prevalence of health systems, surprisingly, we don't know very much about them. For example, what are the differences in performance between these institutions and other institutions? What health system characteristics are associated with better performance? Do high-performing health systems adopt patient-centered outcomes research, or PCOR findings? What factors affect the effective adoption and use of PCOR evidence? What lessons can be learned? Can they be applied to other systems? These are the types of questions that this initiative seeks to understand, to answer, and to spread. The main goal of this initiative is to identify, to classify, to compare health systems, all with the eye towards accelerating the dissemination of evidence that will improve the performance of the health system. To accomplish these goals, AHRQ has partnered with several institutions. First, we are anchored by 3 grants that AHRQ has awarded to renowned institutions. These institutions are Dartmouth, in partnership with Berkeley, the National Bureau of Economic Research, RAND, in partnership with Penn State. We are also partnering with Mathematica Policy Research to coordinate activities across the 3 grants and to disseminate findings. And finally, AHRQ staff is contributing to this effort with research and data development activities. So using this team, this initiative is going to take on 3 broad activities. First, we're going to create and disseminate databases. We are going to conduct research and analysis and develop the evidence base. We're going to disseminate these findings and the evidence to promote the learning health system. So what are some of the things that we are now doing? A major project of this initiative is the compendium of U.S. Health systems, a database that was developed that documents all the health systems in the U.S. Now, Sharon mentioned this earlier during the AHRQ update, but just as a reminder, the first release was made available in September. That identifies over 600 U.S. health systems, and we have over 25 organizational attributes. Again, this is the first publicly available database that provides researchers, policymakers, healthcare administrators with a snapshot of the nation's healthcare systems. The compendium will be continuously updated with new information, and a goal of the compendium is, in fact, to foster greater understanding of the characteristics and the practices of high-performing healthcare systems. In addition to this, there are over 90 planned research topics that will produce the evidence that we hope to disseminate to improve the delivery of healthcare in the U.S. These topics are actually quite varied. For example, we have a set of research topics that investigate the role of health system integration and how that plays on quality, cost, and delivery of care. We have studies that look at how different management approaches and care transition strategies might impact outcomes. These are only some of the areas that we hope to gain a better understanding and to disseminate the findings. So to conclude, this initiative seeks to identify the characteristics of health systems associated with better outcomes, We are identifying and comparing health systems, all with an eye towards accelerating the dissemination of evidence that makes the system works better. And this initiative has a core feature of what AHRQ has always been known for. We create and disseminate databases, we conduct research and analysis and develop the evidence base, and we disseminate the findings. I'm happy to take any of your questions.
Lucy, applause first. Lucy.
Lucy.
So I have one comment and then one question. The comment is that NPR has an article coming out in November and a special issue I commissioned for eGEMS that'll talk about some of the data issues I think people will be interested in seeing. And then the second thing, which is my question, is are any of the projects looking at the opportunities for public-private collaboration with these systems as they become learning health systems? Because many of them are dependent on federal funding to actually fund the research that's being done in the learning healthcare system.
So first of all, thank you for the comment and that additional information. As I mentioned before, there are a number of different projects. There's over 90 planned research projects. In many of the centers of excellence in our partnership, they are in fact partnering with systems to kind of get into that space of trying to understand the data issues, how can data be shared, but also to try to produce that evidence. So I would have to ask my team to actually delve into some more details about the project that the characterization that you have mentioned, but I'm sure there's some elements of that. That's the way I would characterize
So
it.
let me just clarify, because I think it's important to understand that that project isn't necessarily about learning health systems. What we're trying to do there is characterize health systems, and then the research will try and kind of characterize them. Some will be learning, some won't be. But the definition of health systems you might want to talk about is, hospital affiliated with a certain number of physicians, and there's kind of ownership relationships. So we had to come up with a definition of what's a health system, and the definition of a health system doesn't include the definition of whether there's learning going on right now, at least at the initial stage.
Yeah, but I think it's an important attribute to look at while you're collecting the data and reaching out.
Yes, thank you. Good observation.
So health systems are evolving, consolidating, growing, getting bigger, and they're on different points on their journey toward working together, toward figuring out how to be a learning organization, so on. That process itself is something to understand and to learn about and to study. So how are you taking into consideration the evolution of these systems, and how do you characterize that evolution so that if someone wonders what they can learn, they can find groups that are like them or at their stage of their journey and so on, which I think is a very important piece of the next 10 years as we're going to see this consolidation into smaller numbers of big ones, and how they deal with community hospitals and how academic hospitals perhaps link together, because the future will be systems that have more than one academic health center in them and so on.
Yeah, so that's a great question, Bob. So one of the key things that we have recognized is that over the last several years, the explosion of health systems. And we go into a situation where we struggle, in fact, to define what a health systems in fact is. We do have a compendium that is based on an AHRQ definition that got incredible input from technical expert panels and others. But one of the key features that we're looking for is that understanding component, that once we have this information, characteristics of the systems, including some element of where they are in the development process. So for instance, if we identify a handful of systems that are, in fact, quote unquote, long-standing, they've been existing for many years, well, that's going to be an important feature as we look at how well those systems can perform, compared to, say, another system that may have developed over the last 2 or 3 years. Some categorization or understanding of that evolution process of where they are might be an important feature in terms of where they have. I see Jamie raising her hand, so I think I'm overstepping my bounds here.
Thanks.
Okay, thank you very much.
Good afternoon. My name is Tess Miller, and it's my privilege to be part of the Evidence Now team at AHRQ. I'm also delighted to tell you why AHRQ has selected Evidence Now as an exemplar project to promote learning health systems. Evidence Now, which began in 2015, is a 3-year initiative that features over a decade of AHRQ's work to support and study primary care transformation. It's our hope that Evidence Now will create a blueprint to build a primary care system that delivers high-quality, patient-centered care for all Americans. Evidence Now is one of the largest studies of primary care, features 1,500 small to medium-sized practices with 5,000 primary care providers serving 8 million Americans. The goals of Evidence Now are ambitious, and they include helping practices implement evidence to improve the quality of heart health care, helping practices identify ways to build their capacity to identify and use evidence in other PCOR findings in the future, studying how external support helps primary care practices improve the way they work and the health of their patients, and lastly, building and disseminating a blueprint of what works to improve primary care. So what exactly is Evidence Now?
Pardon the interruption. Your conference contains less than 3
That doesn't go
participants
towards
at this time.
my minutes, right?
If you would like to continue, press star
Through a
1
competitive
now,
grant
or the conference
process.
will be terminated.
There we go. Through a competitive grant process, AHRQ funded 7 regional cooperatives. Each cooperative has recruited and engaged with 250 small to medium-sized practices. The cooperatives have also developed unique interventions designed to improve the delivery of cardiovascular care focused on the ABCSs: aspirin use for high-risk patients, blood pressure control, cholesterol management, and smoking cessation. Each intervention includes a combination of 5 quality improvement services that are typically not available to small practices because of their size. These include practice facilitation, health information technology support, data feedback and benchmarking, peer-to-peer learning, and expert consultation. Each cooperative is evaluating the success of their intervention in both changing primary care practice and improving cardiovascular care. AHRQ has also awarded a grant to a national independent evaluation team to study the effect of interventions across all 7 cooperatives. In addition, the evaluation team is studying which practice support services and quality improvement strategies are most effective in improving the implementation of new medical evidence. Baseline data indicate that the cooperatives were quite successful in recruiting a broad range of small primary care practices. 25% of participating practices are solo practices, 19% are located in rural areas, and 1 in 3 are in a medically underserved area. Baseline data also show that many smaller primary care practices are doing an excellent job of providing cardiovascular care to their patients. Some practices participating in Evidence Now are already near or exceeding the 70% goal for 1 or more of the ABCSs. Other practices, though, have some room for improvement. For example, at baseline, 63% of patients who smoke or use tobacco are provided counseling and medication to help them quit. Evidence Now was designed to be customizable to the needs of a practice. Some practices are doing really well on 2 of the 4 ABCSs and wanted help with the other 2. Other practices were not even sure how well they were doing and needed help to learn how to use their EHR to pull reports on standard quality measures. Still, other practices have change fatigue and need to re-engage with quality improvement work and find ways to restore the joy in practice. So why did AHRQ select Evidence Now as an exemplar project to promote learning healthcare systems? First, Evidence Now is helping small to medium-sized primary care practices identify and use new evidence, in this case on heart health care. More importantly, though, Evidence Now is helping practices to build capacity, which we hope will enable them to identify and use new evidence in other clinical areas after Evidence Now ends. Evidence Now is helping primary care practices learn how to extract data from their EHRs and use it for performance measurement and quality improvement. In fact, we're learning a lot about the challenges of using EHRs for quality improvement in primary care. It's our hope that in the future, building on what we learned from Evidence Now and will be able to share, primary care practices will be better able to use their own data to improve the delivery of care. Clearly, Evidence Now is helping primary care practices take this new knowledge and implement it in practice. Lastly, through Evidence Now, AHRQ is learning how to best support any small or medium-sized primary care practice in becoming a learning health system. Hopefully, we will demonstrate that you don't have to be large and integrated, that even small primary care offices can become learning health systems and improve the care they deliver. Thank you. Any questions?
That was a very nice, Tess. Will you learn about sustainability? You know, so after you disengage, do these folks go back to baseline? And
So we don't have plans right now to study, actually, future with these practices. We're hopeful. But we are learning a lot about sustainability at the cooperative level and how that infrastructure can continue. And there's a lot of different potential models because of the different ways cooperatives have formed. So we'll certainly learn about how you might continue to provide external support to primary care practices. Thank you very much.
Good afternoon. I'm Jim Kleeman, Director of the Division of Healthcare-Associated Infections at AHRQ. I'm delighted to have this opportunity to talk with you about AHRQ's Comprehensive Unit-Based Safety Program, or CUSP. CUSP is a proven method for preventing healthcare-associated infections, or HAIs, and other patient harms, and thereby improving the safety of healthcare. And CUSP is a critically important component of AHRQ's HAI program, which sustains a robust portfolio of research and implementation projects to prevent HAIs. CUSP was developed at Johns Hopkins with AHRQ support, and it was later shown to be effective in reducing HAIs in over 100 ICUs in Michigan. CUSP combines improvement in safety culture, teamwork, and communication, together with a checklist of practices known to be effective in reducing the target HAI or harm. Now, we've had checklists and guidelines forever, and we're all aware that these guidelines are often honored in the breach and frequently not adopted by clinicians who continue to practice as they're used to doing. Moreover, several analyses have estimated that the average time it takes for medical innovation or research evidence to diffuse into practice is about 17 years. Clearly, translating evidence into practice is a significant challenge, as well as a core component of learning health systems. In this challenging space, the CUSP combination of behavioral elements, emphasis on safety culture, teamwork, and communication, and clinical elements, the checklist of proven practices, is a powerful tool for accelerating the adoption of evidence-based practices to prevent HAIs. In particular, the behavioral elements of CUSP help the clinical team develop a sense of ownership of the problem of HAIs, which is crucial for preventing these infections. AHRQ's HAI program has implemented CUSP in a series of nationwide projects that have shown CUSP to be highly effective in reducing rates of various HAIs in different care settings. In fact, success of the early CUSP projects helped to transform the medical community's perception of HAIs. Whereas they were previously regarded as an unavoidable complication of care, the price of doing business, if you will, they are now recognized as being largely preventable. CUSP's track record is gratifying. CUSP has reduced central line-associated bloodstream infections by 41% in over 1,000 ICUs, reduced catheter-associated urinary tract infections, or CAUTI, by 30% in over 700 hospital non-ICUs, reduced CAUTI in long-term care by 54% in over 400 nursing homes, and reduced surgical site infections in hospitals by 25 to 40%, depending on the type of surgery and the surveillance method. CUSP is a prime example of AHRQ's leadership role in translating the evidence from research into tools and programs to accelerate the adoption of proven methods into practice, and thereby improve the safety and quality of care actually delivered to patients. The nationwide CUSP projects exert their quality improvement influence through a multifaceted implementation framework that includes the following: engagement of frontline clinicians and institutional senior leadership, education in the science of safety, assessment of safety culture, expert coaching and technical assistance, data collection and feedback for performance monitoring, and patient and family engagement. In addition, the projects develop toolkits encompassing all of the educational interventions to extend the impact of the projects beyond their duration. Seen from the perspective of learning health systems, the CUS projects most directly occupy this space from evidence to practice. They clearly translate evidence into practice by accelerating the adoption of evidence-based practices to prevent HAIs. But beyond this, the CUS projects relate also to other arms of the learning health system continuum and actually constitute mini learning health systems. The CUS projects not only translate evidence to practice, they generate data on changes in care processes and outcomes in the projects. And these data are then used to evaluate the impact of the interventions and modify them for greater effectiveness. And the data and lessons learned from the projects are used to formulate additional research questions and generate new knowledge. So in summary, CUSP accelerates the adoption of evidence-based practices to prevent HAIs and thereby improve the safety of healthcare delivered to patients. And the CUSP nationwide implementation projects exemplify the characteristics of learning health systems. That's my story, and I'm sticking to it, and I'll be glad to take questions.
Very nice. A couple
Thank you.
questions. Trying to understand AHRQ's role in this. So are you running these? Are you submitting out RFPs where investigator-initiated projects roll in the general area? Or do you have targeted work that you want to do that people apply to do? What's your role in that?
These are quality improvement projects, not research per se. We contract with, we put out a request for people to bid on the opportunity to run these projects. We have a stable of contractors called the action contractors who are ready to bid in quick fashion on projects like this, maintained by our sister center, CDOM, that action contracting mechanism. And the contractor then leads the project with our funding and our guidance. We are very involved in steering what is going on in the project, but there is an intermediary group. In one set of cases, it was Johns Hopkins. In another set of cases, it was the American Hospital Association's Health Care Research and Educational Trust. And they then have a whole set of subcontractors and experts who work with them. So it's a very integrated set of people who do this, but it's basically, if you'll forgive the expression, work for hire. We know what we want to accomplish, and we're asking people to help us get there.
So my second, well, thank you, that was very helpful. My second question is in the metaphor of personalized medicine or prognostic stratification, as Feinstein threw it out there in '68. But thinking about the process of care, so you mentioned that you were trying to learn, not just improving care, but you're trying to learn what processes and best practices work. So at some point, you might be able to describe hospitals or units that have certain characteristics, and if they're in those characteristics, here are the kinds of processes and approaches that had been found to work when you're trying to address these problems. So I'm this kind of unit, I have these kinds of characteristics, I'm facing this kind of problem. What are the opportunities for me? Can you organize your information in that kind of way to get that degree of specificity? Because it would seem like you may have the data to do so.
There has been some attempt to characterize and find out what works in which setting. So for example, a follow-up research project to our very successful nationwide CLABSI project, where you had a 41% reduction in the rate of central line-associated bloodstream infections in intensive care units, ICUs. A follow-up research project found that several characteristics of the most successful ICUs helped the effectiveness of the intervention. So for example, aggressive goal setting was very helpful for that set of ICUs, and interprofessional education was also a very strong indicator of whether the project would be more successful or less successful. So we do have information of that sort, although I wouldn't say that it was totally comprehensive. Jamie, are you asking a question? No, thank you.
She's waving goodbye.
Good afternoon, everyone. My name is Harry Kwan, and I'll be talking about the Learning Health System Researcher core competencies. So we're going to start off with an imagination exercise here. So Imagine your daily commute, whether it's to the office or to the clinic or even here. If you travel by car, there are probably many factors that were involved, such as monitoring the traffic conditions, ensuring that you have enough gas to get to where you want to go to. If you're running late, looking out for speed traps. And for some, like myself, trying to make sure to identify where the nearest coffee shop is on the way to work. But now imagine if you're a researcher embedded in a health system where point B is improving quality and health outcomes. So this involves developing, synthesizing, and incorporating new evidence into practice. So pretty much attributes of the learning health system. Researchers in a learning health system can analyze system data, develop quality improvement strategies, test these strategies, and refine these strategies in real time. The challenge, however, is that limited attention has been given to the unique attributes of these researchers, as well as providing the adequate knowledge and skills in order for these researchers to be successful in conducting research in learning health systems. So recognizing this need and challenge, AHRQ commissioned the development of core competencies to guide the training programs for learning health system researchers. Through this work, there were 7 domains that were developed focusing on these competencies. And they are briefly, the first one, system science, understanding how systems, how things work in health systems. The second one, research questions, making sure to asking the right questions and the ability to evaluate the science. Research methods, knowing how to conduct research using the appropriate designs and methods, but also conducting research in complex settings. Informatics, knowing how to use the information systems and sources in order to conduct such research. Ethics, ensuring that research is done the right ethical way. Implementation science, integrating the knowledge generated from the research at the point of care. And finally, engagement and leadership, employing the skills to engage a variety of stakeholders across the research continuum and leading teams. There are about 33 competencies spread out through these 7 domain areas. So it is not expected that any one person becomes an expert in all of these domains. However, if there is one, I would love to get their autograph because they'd be an amazing researcher. And as you know, learning health system research requires multiple disciplines to work together to produce and use system data to improve outcomes. And right now, AHRQ is at a pivotal point in research training, from building upon all the work that we've done and supported in traditional health services researcher training, to focusing on training the next generation of researchers, these learning health system researchers, to help us to get to this point B, improving quality and health outcomes. This is what researchers, clinicians, and patients care about. And as Sharon mentioned, I'll be concluding this, as Sharon mentioned earlier during the updates, we are very excited to have, working with our, with the Patient-Centered Outcomes Research Institute, PCORI, to announce this latest funding announcement on learning health system researcher training through our institutional training program. Information about this funding opportunity announcement is on our website, and applications are due at the end of January. So at this time, I'd welcome any comments or questions. Thank you. Thank you. Thank you. Thank you.
So we hear a lot, thank you, that's very helpful. We hear a lot about, and over the years, interprofessional education. And perhaps a little less about interprofessional, interdisciplinary research. And this learning healthcare system seems like among the competencies that we might forget about are the ability to bring together these disparate groups of people and function in a way we're not used to functioning. Exactly. How to communicate, how to listen, how to talk, how to create the transdisciplinary solutions that we might need. Is that part of your training, or are you going to conduct research to try to push that so we'll all get better?
I think that it's a little of both. As this is what's unique about this is the first time that we have these competencies available specifically to the researchers. And there are a number of other competencies out there that sort of delve into those areas, such as communication, such as team work and team team dynamics and team science and so forth. So this is at the beginning. As we go through, continue on, just like making real-time improvements in the health system, we're going to make and explore opportunities to really engage in our competencies or the competencies that we developed and look at how we could either improve or expand on these as we move forward, as we engage through this, this journey moving forward. So, yes.
So are you thinking at all about how to, I guess, create an evidence base around the importance of these competencies? So this right now, as I understand it, is best thinking of what we think people need based on a lot of experience. But is there any opportunity to provide information about the importance of it?
No, I think as we move forward, I mean, we have information about these competencies on our website and how we got to this and the work that's been done there. But through this training program that we have coming up, this wonderful opportunity, we have a learning collaborative that's going to be a key component of this. And through that, we'll be able to, develop and explore curricula and ways to how these competencies are working in this training program, as well as opportunities to explore what other competencies may be needed or explored as we continue on through this training program. So.
Yeah, I guess what I'm thinking of is demonstrating that if you have, say, a team that collectively has these competencies, the odds that you'll be able to really make changes in the systems that those folks are involved in are greater than if you don't have the competencies available. So it's really, can you demonstrate that it produces the outcome of interest, which you talked about what your ultimate goal is.
Sure.
What Beth said, I think it's what's the critical mass that's needed. Like one person alone.
Sure, exactly.
Say what?
You need to write a grant to study that.
Perfect.
Okay, I'm sure you're ready to go on to the next session, so I will be brief. My name is Erin Grace, and I will be sharing with you some information on AHRQ's competencies and capacities in measurement-powered quality improvement. We know that one competency of a learning health system is the ability to embed evidence-based practices, such as research from outside sources, into the everyday care provided. Learning healthcare systems also use internal data from the system's own experience to inform how healthcare is delivered in a continuous learning cycle. One of AHRQ's core capacities that addresses this competency of a learning health system is developing and using evidence-based, robust measurement tools to improve the quality and safety of healthcare. How does AHRQ do this? As a research organization, we start with the science base for measurement, given the data source or data sources available, be it claims and billing data, patient experience survey data, or registry data, as a few examples. We also know the attributes of a robust measure. We use the science to understand the data and then develop robust measures with sufficient understanding of the measurement methodology, administrative data versus survey data, as an example. And two examples that I'm going to talk to you about right now of this approach are AHRQ's Quality Indicators Program and AHRQ's Consumer Assessment of Healthcare Providers and Systems, or we refer to it as CAPS, Patient Experience of Care Surveys. Quality indicators, or QIs, are standardized, evidence-based measures of healthcare quality that can be used with a hospital or system's readily available hospital inpatient administrative data to measure and track clinical performance. CAPS surveys solicit important information from consumers and patients about their healthcare experience. Surveys cover topics important to consumers and focus on those aspects of quality that consumers are best qualified to assess. CAPS surveys are built on a set of evidence-based design principles that are intended to ensure the quality, comparability, and consistency of CAPS products over time. The QIs and the CAPS surveys capture data that provide important insights based on different types of a healthcare system's internal data. The QIs from claims and billing data and CAPS from patient survey data. AHRQ's measures related competencies in building capacity for learning in a healthcare system are not limited to the data and measures alone. AHRQ also provides tools to help healthcare systems implement the measures appropriately, and more importantly, to use the results to actually improve the quality and safety of the healthcare delivered by the healthcare system. For example, healthcare systems can and do use AHRQ's quality indicators software to generate organizational level or area level results that can be used to identify areas for improvement and track improvement over time. AHRQ has also developed a hospital QI toolkit to help hospitals understand the AHRQ QIs, specifically the patient safety indicators and the inpatient quality indicators, to support use of the results to improve quality and safety in hospitals. The toolkit also follows the quality improvement process that includes setting priorities, planning for quality improvement, implementing improvement strategies, tracking progress, and sustaining the improvements achieved. AHRQ has also developed the prevention quality indicators that can be used to examine areas for improvement within the community or an expanded healthcare system. Moving to our other example, CAHPS, the surveys are used by healthcare systems to measure their patients' experience of care. The CAHPS Ambulatory Care Improvement Guide is a comprehensive resource for health plans, medical groups, and other providers seeking to improve their performance in the domains of patient experience measured by CAHPS ambulatory care surveys. Organizational use of the guide can help to cultivate an environment that encourages and sustains improvement in patient-centered care. The guide helps healthcare systems understand how to analyze the results of CAHPS surveys and other forms of patient feedback in order to identify strengths and weaknesses and develop strategies for improving performance. The guide includes a walkthrough of the basic steps of a CAHPS-related QI initiative, determining where to focus efforts, and how to implement strategies to improve patient experience in the ambulatory setting. Finally, medical offices and group practices, as well as health plans, can voluntarily submit their results to one of the AHRQ CAHPS databases for a customized report that can be trended over time and aggregated to facilitate comparisons of CAHPS survey results with other submitters. Thank you. Comments, questions?
Have you taken the pain question out of the CAHPS?
The pain questions were changed, and Sherry may even be able to speak better to it, but they're more focused on, did your doctor talk to you about your expectations for pain management, as opposed to, yes.
Hi, this is Don on the phone. Can you hear me okay?
Yes.
Yep.
Just a couple questions. One about the CAHPS and the other one about the QIs. So do you have a sense of what organizations are doing with the tools you've developed to help them use the results?
And
Hey,
Don,
Don, can you mute your computer because we're getting feedback?
Sorry. It is muted.
Somebody else, I think, might have joined the call.
Yeah. There we go. So Don, could you repeat the question? I'm not sure that Aaron could hear you.
I was the good phone person. So I was asking whether for the QIs, you have developed these tools to help organizations understand their data and use it to drive improvement. Do you have some sense as to who's doing it and what they're learning as a result? And for the CAHPS, do you have a plan for beginning to deal with the use of NLP to identify themes that aren't captured by the quantitative data?
And Don, you were at the Learning Health System Summit, weren't you?
Yes.
I think you asked the same question.
I did. And, now we have a different
and I guess I didn't give a good enough answer.
I didn't ask the one about the QIs, just the one about the CAHPS.
And I'm looking in the room for my colleagues to answer the question from the QI's perspective.
So we used to try and track where they were being used in the past, but it's really hard because these things are up on our website. Anybody can pull them down. So we can reach out to states to find out, which of our state partners kind of know about use, and we can talk to AHA and others. But this is something that's really hard to track because once we develop these measures, we make them a public good, and there is no way to really kind of track who's using them other than survey, word of mouth, et cetera. And frankly, we have made the decision that our resources are best used to develop new tools and resources and help people use them rather than to track how the existing ones are being used. May not be the right decision, but that's how we've decided to use our scarce resources.
Yeah, and I would say that the same is true for the CAPS surveys and the CAPS QI toolkit. The one thing we have, which is not a comprehensive sort of review of who is using them, but we do have impact case studies on our website. So either staff at AHRQ know of a grantee or an organization that is using our tools and has had some success. Or the grantee themselves says, oh, hey, we did this great thing because we used the QI toolkit. And then our Office of Communications turns those into impact case studies. So we have, sort of stories about certain institutions, but not an overall evaluation like Sharon said.
Thank you.
All right,
Great.
next session. Thanks.
Thank you so much. And no, I would say that I hope that you capitalize or continue to capitalize on having put this together, because I think kind of back to a point Bob made earlier about being able to tell the story about the contributions, and I actually found myself wanting to organize them in some sort of a chronologic, first you need to know something about the systems, then you need to know about the competencies of the systems, and then you need to know what kinds of approaches they're taking to improving. I mean, so I think there's a way to almost build a graphic that highlights your programs, but shows kind of where on the journey you are making a contribution. And then there's a chance for you to talk across what you're doing about how the pieces work together. So I think you should take it on the road. Okay, so trying to get my game plan here. Okay, so we're turning now to an update on AHRQ's Patient Safety Learning Labs. And we have a panel with Jeff Brady, who I think most of you have met previously, who is the director of the Center for Quality Improvement in Patient Safety. And Kerm Henriksen, who is a senior advisor, human factors and patient safety at AHRQ, and then Alan Ravitz, who is a chief engineer, National Health Mission Area for the Johns Hopkins University Applied Physics Laboratory, which is very impressive. So, Jeff, I'll let you, I think, introduce where you're going with this.
Great, thank you. Can you hear me okay? Perfect.
Talk loud. Yeah, do a form on there.
Talk loud, I'm told. Okay, so I know we're a little over time, so we're going to try to make up some of that, but it's really a pleasure to be with you today to talk about this initiative that we started not long ago. And so, as was mentioned, I'm joined by Dr. Kerm Henriksen from our patient safety team and Dr. Alan Ravitz from Johns Hopkins Applied Physics Lab, who's representing one of the funded grantees from this initiative. So I was actually watching the early part of the session from our office today via the web, and I was really pleased to hear the question about breaking down silos and encouraging the formation of interdisciplinary horizontal teams to solve problems. The initiative that we're going to describe to you today is in the session is doing exactly that. So I think we're very much in keeping with that theme that has come up at least a couple of times throughout the course of the day. Before we start, I want to acknowledge the small but mighty team behind this initiative. Again, my co-presenter, Dr. Kerm Henriksen, he's one of the senior scientists on the patient safety team, and some other team members, I think at least one, Dr. Barbara Bartman, is in the room with us today. Others, David Roderick, Denise Burgess, Daryl Gray, and Emily Chu, have really allowed this to be the successful effort that it is. Let me make sure I've got the right page now. Okay, so essentially what we are going to describe to you today is a collection of 13 projects. These have been awarded in two cohorts starting in 2014 and then the second in 2015. At the heart of these projects are multidisciplinary teams, and the bulk of their work is the application of a systems engineering methodology and some design thinking that approach that is to address related patient safety threats and develop solutions appropriate for this methodology. I got some helpful advice about this presentation to give you some concrete examples at this early point to let you know the kinds of problems that we're talking about. One is this issue that we've all heard about of alarm fatigue, so you don't actually have to be a clinician to appreciate that. If you've ever visited someone in, the hospital or even in, the emergency department in the clinical space, you know about this issue, and that's when you have multiple uncoordinated devices with their independent alarms, firing at different times. Some of those are false, some of those are true alarms, but it's really left to the clinician who has many different tasks to complete to figure out which are the ones that need to be paid attention to and which are just distractions from other important things that they need to be doing. So that, just imagine that sort of system of things happening where they're actually not happening in a way that's conducive to safe care. Another quick example is thinking of the operating room and the risks that are present in that environment. This set of threats also is conducive to this approach if you consider distractions, again, from repeated interruptions of people entering and leaving the OR, not to mention the potential for higher infection risk based on doors opening, et cetera. And so considerations about the built environment and the physical space. And then finally, another example is in the domain of maternal and fetal health and the impact of impact on safety of data displays that are either supporting or not supporting effective care that clinicians are delivering. So is that information organized in a way that is easy to read? The team can sort of see it, develop a shared mental model of what's actually happening with the patient in this sort of high intensity example of care. And then other aspects of the physical space, has the design actually kept up with changing practices? And we'll say a little bit more about that with the specific project that's addressing that. So that is, in a nutshell, just a thumbnail of the projects that we're going to talk about. Our agenda in the next few minutes is to give you a little bit deeper rationale for this group of work, the Patient Safety Learning Laboratories. We're going to give you some additional highlights of these projects, talk about some progress and challenges that the grantees have faced, and then ultimately where we really want to get to is your feedback about this somewhat novel set of work that we embarked on, again, just a few years back. So for some time now, the field of patient safety research has acknowledged the value of a systems approach to address patient safety problems. We've had reports from national organizations that have called for closer engineering and healthcare partnerships to accelerate improvements and lower costs. And in spite of that recognition, these perspectives and methods have, and the potential that they have to provide, there has been really a scarcity of redesign and systems engineering activity. One key advantage of a systems approach is the potential to address not problems one at a time, but sort of a collective set of related problems, patient safety harms, again, rather than these singular concerns in a piecemeal fashion. So it's really simply applying a systems approach to systems problems when you really boil it down. So our overarching objective with this set of work was to create opportunities for new ways of thinking and learning and for fresh approaches that could be tested and revised and further developed when they were considered to be promising. More specifically, we described in the funding opportunity what the title says, learning laboratories, which are places and also networks. I think that's also at the heart, these professional networks that allow multidisciplinary teams to identify closely related threats to patient safety, stretch their siloed traditional professional boundaries, and engage in some bold design innovations, and take advantage of, again, a slightly different approach than what we may normally take in health services research. As I mentioned, multidisciplinary teams are at the heart of the initiative. We set out in the funding opportunity, had a requirement for projects to include 2 to 4 closely related individual project areas as part of a complete grant project. And again, those needed to be conducive to this design approach so that the synergistic impact of the set of individual projects would be more than just the individual projects themselves. Design thinking, as we've mentioned, and systems engineering methodology, which Kerm is going to say a bit more about that. And then finally, we noted that, as we do in much of our research, patient safety and otherwise, the need to focus on the high cost of care, in particular in under-resourced communities. We sort of highlighted a particular interest in receiving those kinds of applications. So, Kerm.
Thank you. Just to recap or underscore some of the essential aspects of the funding opportunity announcement that we think sort of serve as distinguishing features of learning laboratories. This slide shows six key features that I think are very important and maybe deserve some discussion. The idea of focusing on closely related threats to patient safety. And when we put this sort of requirement in the FOA, the settings of care that we were probably thinking about were those inpatient settings of care that are somewhat self-contained or easily defined as somewhat self-contained units. And so we would be thinking about the most easy examples to think about would be the ICU, the emergency department, labor and delivery units, the operating room. And so these, we thought we would be receiving applications in these areas. But as Jeff just mentioned, we were also interested in the ambulatory care environment. And even though we maybe had some doubts about whether this methodology can really be implemented in a meaningful way. And so we were fortunate enough to fund 2 applications that came in on the ambulatory care side of healthcare. But the idea for closely related threats is that for a systems approach to work, in these different settings like the ICU, there's usually a cluster of harms that occur. And so if we can, this would be the low-hanging fruit for a systems engineering approach because they're readily identifiable. They occur in a single unit. And they need to be addressed from a system perspective to have a more synergistic impact rather than thinking of patient safety as a number of one-off singular studies. Okay, the second criterion or feature that we thought was unique and it is this use of multidisciplinary teams to generate innovative ideas with respect to the threats. And certainly multidisciplinary teams are not unique in any sense of the word. Healthcare services research uses always multidisciplinary teams. But I think it's important to make a distinction between what a multidisciplinary team might be and a transdisciplinary team. When groups of professionals come together from different disciplines and sort of just start their teamwork effort, it's probably justifiable to call them multidisciplinary. They are individuals that come from different disciplines that are representing the point of view or the merit or the major paradigms that are prevalent in their disciplines, and they're offering their advice from their discipline's perspective. And that's fine. And if that's all it is, then the term multidisciplinary team is probably appropriate. But if we really want to become a transdisciplinary team, or we hope that the teams eventually evolve into being transdisciplinary, then we need to sort of transcend the individual interests of our own disciplines, or at least allow those interests to sort of fade into the background and focus on the problem that that the projects are trying to address. And so you lose, if we're completely successful with our team building efforts so that they do become transdisciplinary, we sort of lose our sense of identity as a clinician or as an engineer or as a human factors person. And that becomes less important to have our own point of view heard, but more important in terms of how our skills and knowledge can further the goals of the collective unit that is trying to address the problems in a more holistic fashion. And so that's, we had a meeting just probably 10 days before the Learning Health Systems Summit. We had our own little summit of the Patient Safety Learning Labs in September. And we were sort of, one of the questions that we asked during the breakout sessions were, well, how difficult was it to work with people from different disciplines? And a couple of grantees thought it was a major, it was a feat that was very difficult to accomplish, and that they talked about, gee, we only really started to talk to one another or feel a little bit comfortable with one another after the first 2 years of the project. And so it sort of made our jaw drop a little bit and saying, gee, is that the major accomplishment of 2 years of work, just being able to be comfortable enough to talk to one another? And so, I mean, it was a learning lesson for us, because when we write the program announcement, we have our own vision of what's possible, but that's only our own vision. That's, research as we imagine it, but we're still at the 30,000-foot level. And so when you start to hear the clinical reality from what actually goes on in the clinical setting, that's research as imagined or envisioned does not equal research that actually gets performed. And so that's another one of our lessons learned. And then the environments that are established. The learning laboratory is an area where one is allowed to brainstorm and feel comfortable with coming up with prototypes of new designs. And this is where the design thinking comes in. And we know that the private sector of the economy has made tremendous gains in terms of this technique of brainstorming and rapid prototyping. And this is a place where individuals are allowed to fail. Failure is actually welcomed. The design mantra is fail early, fail often, succeed earlier. And so you want to try out these prototypes in the early stage of development, where it's less costly to fail, rather than at a later stage of development in an implementation or evaluation stage where your costs are already sunk and it's too late to make any sort of changes. So fail early, fail often at an early stage of design rather than much later during implementation. And what goes on in between these two phases is a lot of multiple develop, test, revise iterations of the promising designs. And so there's repeated testing going on. And so a lot of data are being generated, but they're being generated in a fairly rapid pace, extremely purposeful fashion, so that these improvements can be made. And so the idea that Jeff was mentioning, there's 2 to 4 projects that are going on, and eventually those projects should have been identifying closely related harms. And so the idea is, as a result of the design work that goes on, those, by the implementation stage, those designs should sort of evolve or lose their individual identity as projects and become part of a working subsystem or a working system that can be further developed and integrated and validated and then tested in a simulated or a clinical environment. Okay, and so that's these six features are things that sort of define what a patient safety learning lab is all about for us. Okay, and so here's what here's what works in industry, and can we apply some of these techniques from industry to patient safety? And so this is the systems engineering process. Alan will be talking in a few moments about the V model, but it usually starts out with a concept of operations and then an extensive period of requirements and analysis. And in our FOA, we refer to these two first phases at the front end of the process as problem analysis. And one of the mistakes that a lot of even engineering efforts make is they don't give sufficient attention to the problem analysis phase. They have the idea of a potential solution, and they are so eager to put out the fire or to get their ideas implemented that they fail to look at the problems behind the problem that they are addressing. And it takes a fairly extensive period of time to unravel all the problems that are contributing to the problem that you want to focus on. Okay, and then let's see, is there anything else I want to elaborate on there? Yeah, the whole idea is, even with Detroit and automobiles, the cars that we're going to be driving in 2020, the new cars that we're going to be driving in 2023 are currently being prototyped today. And so that car that we will be driving in 2023 is going through this type of design process where it starts out with some rough prototypes, some high-level design, then the design becomes more detailed. There's a lot of revision and improvement, and then usually with small group trials to catch the more obvious things. And as those more obvious glitches are removed, then we move to larger group trials that take more people to catch the finer vulnerabilities. And then the different components of the system have to be integrated. That integration process has to be revised and approved. Before we push the car out the door, it has to go through a full dress rehearsal of all the integrated parts functioning together as a working system. And then here it gets, this phase, it might get tested in a wind tunnel or some other simulated setting, and then it can be adapted to the individual user or to the users in the clinical setting. This is the same thing that I just went through, the V model that Alan will probably talk about a little bit more. The left side of the V shows the sort of reductionistic or the decomposition of the requirements that we want to have in the design. The implementation sort of refers to the further development of the components that need to be further developed, and then the components become integrated into a working system, and that all those system components as a working system need to be validated and verified. And so that's where we put the left side is Humpty Dumpty falling off the wall and breaking into pieces. And now we got to put Humpty Dumpty back together again in an integrated fashion, and that's the right side of the system. Okay, Jeff mentioned in 2014 we awarded we awarded the initial 5 grants, and those are indicated in the gold stars. And then in 2015, money was made available once again to our surprise and happiness that somehow Congress wanted to see more of this. And so we were able to award another 8 grants. And right now, it's sort of been almost a bi-coastal effort. There's not a lot going on in South Dakota or Wyoming, and it would be nice to get applications from those places. But okay, and then we're gonna look very briefly at the first two projects on this list: ambulatory care for at-risk populations, and then also the work of Lou Halamick on optimizing mother and neonate safety. And then we're going to turn it over to Ellen, who will go into a further detail in terms of what the Hopkins APL lab is actually doing. And so just one more, Jeff. Okay, the Ermi Mala Sarkar is the PI for this effort, ambulatory care for at-risk, something got at-risk left off there, at-risk populations, I believe. And so three projects that Ermi Mala is focused on, and the first is test result management, and so ensuring timely and accurate test result management using electronic measures, the EHR, for patient safety notification and monitoring aspects of the care that is delivered. I think they're focused on the NICU in this first project. And they're also interested in characterizing, getting a better understanding of patient safety disparities. The second project is focusing on population management for monitoring high-risk conditions and treatments. And here they're going to be conducting root cause analysis in 5 public ambulatory care settings to identify contributing factors to the patient safety gaps. And then they will be evaluating the impact of the pilot implementation of the patient safety monitoring methodologies that they are employing across the 5 ambulatory care settings. And then the third project is the improving medication comprehension through plain language instruction. And if you have any questions about this, Barbara is with us today, and I know she's assigned to this particular project. But here's what we were shown during our meeting last month. And it's hard to make out, and it looks sort of messy. What we asked the 13 labs to do when they came to the meeting is we told them we were going to have a poster board session, but we didn't want them to feel compelled to develop a highly professional poster that you might see at a conference. Just show us as best you can through maybe just some slides what you're doing in your lab. And even though this looks a little messy, it is a work in progress. These labs are still sort of 3/4 of the way through their period of performance. And so across the top, you see the 5 stages, the phases of the methodology that sort of roughly approximate what the V model in systems engineering is telling us to do. And so starting with a problem analysis, then going into the design phase, then the development phase, and then the implementation and evaluation phase as indicated by those arrows. And then along the left-hand margin there are the 3 projects that we just described, the test management, the at-risk populations, and then the instructions for medication safety for at-risk populations. And so the, okay, and so these were very useful to help us gain an understanding, because we read things in progress reports once a year, but it's good to be able to really get a better sense of what's going on with these meetings. And we were actually trying to start a learning network, and we usually piggyback those on our annual conferences, but since our annual conferences were being sort of changed or not held every year, it was sort of difficult to do. So anyway, this next slide before we get to Ellen is Lou Halamick, and focusing once again on optimizing safety of mother and neonates. And so they've started, they had about 10 projects going. And here are just 5 of them that their presentation actually sort of focused on. And so the first is developing a prototype for maternal data displays to better recognize signs of maternal clinical deterioration, which typically evolves in a very subtle, difficult to detect and difficult to interpret fashion. And so how can we take advantage of enhanced visual techniques to recognize some of these signs? Another project they shared with us was the development and testing of multiple iterations of a floor-mounted obstetric platform for delayed cord clamping. And and they reported, and we'll look at a sort of image of that in a moment. The final prototype has been machined, and I think they've actually put in for a provisional patent on this. Another project was conducting neonatal resuscitations using also new data displays, and the data displays were designed to promote closer adherence to neonatal resuscitation guidelines. Then furthermore, another subgroup of their team is working on the design of an ideal delivery room. They visited 10 sites, and coming back from those sites, they reported that they were all over the board. There was no standardization in terms of the layout or the configuration of equipment. They seemed very chaotic. And so they undertook the process of trying to design an ideal delivery room, and that's still a work in progress. And then another effort that they reported on was refining a prototype for a fetal neonate transition suite using data generated from simulated neonatal resuscitations. And then this is the delayed clamping table that is a new design for them. The underlying need for this is that it's important for mom to spend up to 30 seconds to a minute with the cord attached with her new child. And it has to be done, if it's a C-section operation, it has to be done in a sterile environment. And so this is a table or a platform, adjustable platform, that allows that to happen. There's also a portable warmer that after that minute takes place, and everything's ensured that the baby is breathing normal and it's been stimulated and it's warm. Those blue pads have a warming element to them, and so then the neonate can be put in the portable warmer and then transported to the NICU. And one of the interesting things about Lou's work is the amount of human factors and engineering that really goes into a labor and delivery unit that is needed to ensure a safe labor and delivery unit. Something as small as a plastic dial with oxygen settings on it, that if it's not set on the right level of oxygen, it can lead to very harmful consequences for the neonate. And it was just small little dial that you couldn't see from the indicator or the notch on the knob of the dial on what setting it was. And there's estimates that just redesigning that dial so that you could see what the setting is when you're standing 3 or 4 feet away from it, to make sure that is visible and everyone can see what the level of oxygen is that is being supplied, is very important. And a simple change as a plastic knob that doesn't cost more than $2 can lead to hundreds and hundreds of lives saved. So anyway, we're ready for Ellen, and I've asked Ellen to share with us a little bit about what it is that the Applied Physics Lab does, and then how did he sort of make the transition from working on undersea warfare systems to ICUs.
Okay, yeah, thanks. Before getting into the specifics on some of our projects, which you see listed here, I'll address Kerm's point there. I'm sure everybody here is familiar with Hopkins Medicine, probably less familiar with APL. The lab was founded in 1942 to address a wartime threat. Over the years, the lab's mission is expanded to include national defense, security, and space exploration. Of those areas, probably only the space exploration gets any visibility in the public media. For example, the Pluto mission, the New Horizons spacecraft that flew by the planet, the used to be planet. It was a planet when the satellite was launched. That spacecraft was built and launched and managed the 9-year mission by APL. Right, I came from undersea warfare. My undergraduate degree is biomedical engineering. My first graduate degree was in electrical engineering in 1989. Height of the Cold War, I got swooped up into the defense world and ended up at the lab at APL working on sonar systems and combat systems for surface ships, aircraft, and submarines. Long story, 20 years of doing that, I felt like I wanted to get back to what I was doing as an undergrad, get into the biomedical and healthcare field, which fortunately I could do while still staying at APL. Just having watched sonar operators on aircraft, submarines, and surface ships, and then watching healthcare professionals do their jobs at the bedside, there are lots of similarities in terms of command hierarchy and also individuals doing heroics with devices and sometimes clunky technology that doesn't really meet their needs and their workflows. There's lots of parallels, which we can have a whole separate discussion about. It should be, it's always interesting. So I guess over the course of the last 8 or so years, we've had the opportunity to work with Peter Bronevost's team in applying a systems approach to patient safety and quality projects. And the 3 projects that I'll talk a little bit more about will give you a sense of how we're applying that systems approach. I have to go to the next slide. Now, I just use the term systems approach. You hear that term a lot. You also hear systems engineering. You hear systems engineering approach. So what I thought I would do is take 2 slides here to just orient at least what our perspective is on those terms. So we view the systems approach as being built upon 2 components, one systems thinking and then the other being systems engineering. So this slide addresses the systems thinking component here. And as I'm going through the 3 projects that we're performing under this grant, they may seem unrelated, but they're really purposely designed to be part of a system engineered to be highly reliable. And that holistic view is essential to systems thinking and implicitly the systems approach. And so each of these projects, we're recognizing the causal interrelationships among culture, workflow, and technology. And we start the project or the development of the concept for the project with scalability and reproducibility and translatability to other settings and whatnot. It's inherent into the design. And as importantly as so is learning and accountability. That we know that there are many unknowns when we venture into something like this, and we need to facilitate a process for learning and feeding back into future iterations. And while we focused our collaboration in the ICU, which is an area of high cost and high risk, but also potentially high gain, the approach we're taking results in solutions that we think we can be scaled outside the intensive care unit, outside of Hopkins, and that's really what our goal is to address these challenges more holistically. So the other side of the systems approach coin is the systems engineering methodology that Kerm had on a prior slide with the V diagram. We refer to this as the system development life cycle. And just want to almost caution some of the language here when I say system development lifecycle. System does not mean just technology. We're talking system with a capital S, if you will. It's culture, workflow, training, maintenance, it's the whole, whatever it takes to put a solution in place. So I've dressed up the V diagram a little bit relative to what Kerm had shown earlier with some additional annotations to emphasize the various activities that go on as we evolve through the system development lifecycle. It starts in the upper left when you gather a group of subject matter experts who are very well steeped in what the current state is and the problem you're trying to address, and they can also help us think through what the future state should be. And there's a process of developing what we call the concept of operations or ConOps, where we baseline the current state and then envision the future state. We decompose in a reductionist kind of way, as Kerm mentioned, that holistic view down into its components along the left side of the V. We implement solutions in terms of building solutions, designing solutions, and then integrating them, and finally working up the right side where we verify and validate the systems that we have that we've recomposed. Each of the activities on this V diagram have formal methods and processes that we follow, but I'll emphasize that those processes can be tailored because not every project requires the same level of rigor in each one of these areas as others. And another thing to emphasize here is the importance of user involvement throughout the process. The presence, the voice of the end user, the people affected by the solution that's going to be put in place is essential as we progress through this life cycle. So what we've done through this grant award is to refine and codify this approach as it applies to healthcare, and so that in a way that others can adopt it and scale it in their areas as well. So just a slide on each one of the three projects. The first project focuses on developing ConOps, or concept of operations, for the harm-free ICU. We're focused on a particular harm, in this case as a case study, that being pressure ulcer prevention, and we're drawing on a simplified ConOps you see illustrated by those multicolor hexagons there. Six-sided figures, I guess they are, or maybe they're 8. The octagons. They represent a scalable and modular generalizable model that we can use to apply to harms, and as sort of a beacon for our team to focus on addressing, defining the problem we're going to solve, agnostic to the solution. It helps us level set ourselves to understand the problem to a great deal without jumping to conclusions about what solution is going to solve the problem. We spent a good bit of time understanding the various use cases, in this case around pressure ulcer prevention. We understand who the stakeholders are. We understand what metrics are important. We try to understand what data is needed, what information is needed, where data and information resides, where it needs to go to, how it needs to be communicated. And then there are other aspects like regulatory concerns and policy issues that need to be factored in into the development of the ConOps. And to elicit all these dynamics and bring them to the surface so we can codify them in the concept of operations, we use various tools such as rapid concept development, prototyping, design thinking. We're using a tool called Quality Functional Deployment, or QFD. That's a tool that was developed in the automobile industry to capture user requirements and prioritize them. And we also are using a simulation workshop to assess various concept trade-offs. And what we're doing with all this effort is refining essentially a roadmap that will allow us to define a ConOps addressing high reliability across not just the IC but other care units as well. Second project addresses the problem associated with productivity and errors that can happen in high-risk medication administration. Our case study in this particular case is focused on insulin delivery. The current protocol, which you see illustrated graphically in the upper left and then a little bit in the words on the upper right, involves a nurse interacting with the medical record, with the infusion pumps, with supplies, and so a number of different manual steps, including manual calculation of dosing that has to be entered in manually into the infusion pump. There's also a productivity implication here because a second nurse has to come and validate the calculations that the first nurse had done. And when that second nurse is done doing this validation, goes back to what they were doing before. This happens on a recurring basis, potentially hourly, depending on the medications involved, and depending on the patient involved, it could happen for multiple medications for a particular patient. So there are issues with productivity, inefficiencies, and potential for error that exist in the current state. So the problem we're trying to address here is to try and potentially automate some of those steps to eliminate the inefficiency and error, potential for error, which you see characterized in the lower left and right. So we've implemented what we call the smart calculator that automatically pulls information out of the medical record, performs the calculation that the nurse would otherwise be doing by hand. And instead of bringing another nurse to the table to validate those calculations, we're essentially using the computer and that original primary nurse in a automation and validation companion approach. In the third project, while most of our effort to date is focused on sort of patient level safety risks and mitigating those potential errors that may occur at the patient level, Project 3 is more at the unit level because we recognize the causal interrelationship that exists between patient risk and unit level risk and stress. And what we're trying to do with Project 3 is capture a signal that says the unit is in stress and therefore potentially that could affect the occurrence of preventable harms. So this illustration is a causal loop diagram that identifies some of the data streams we're going to tap into. We're going to apply machine learning to the data feeds that we're tapping into, and then looking at how this dynamic model may help us put a palpable finger on the level of stress in the unit, how that might ultimately affect outcomes and safety. So to wrap up, this is a snapshot of some of our early findings on Project 1. We think we've laid a basis here for solving larger operational challenges using a codified and refined concepts of operations approach. In Project 2, where we're looking at the bidirectional communications between the smart calculator and the medical record is a sort of a prototype for something that could be applied where other devices are involved. And then on Project 3, we're looking at capturing sort of high-frequency data and using machine learning to characterize potential determinants of error. And just the final takeaway there is the importance, I think, of bringing together that transdisciplinary team that we've stood up.
Okay, great. You mean just to do this, Carl? Yeah. So,
yep, go ahead.
Yeah, okay. So thank you, Alan. Really appreciate that. I think, my overall takeaway from these projects is just in my own experience, they're addressing things that typically have been taken for granted, I think, throughout, healthcare, things that just are supposed to happen in the clinician's mind. I write the order and then it just happens. Well, I think we know that it doesn't happen. So, if it seems like a very hyper-deliberate process, I think you're hearing it very correctly. This is really deconstruction, as you've heard, and very detailed look at individual components of care itself and then putting those back together. So we're sort of embarking on new ground, I think, to some extent. So just really quickly, because we want to get to your feedback on this, I think some takeaway challenges and lessons learned that we have from this set of work is, as you've heard, building multidisciplinary teams is not easy. It doesn't just happen. Kerm described well, it takes a fair amount of time. Different grantees commented on, I think, their own institutional bureaucracies that, those weren't always exactly conducive to this kind of work, and in some cases served as an impediment. Probably no surprise, but helpful to document that and maybe understand it in a little bit more detail. There was also, I think Alan touched on this well, an appropriately flexible approach to the systems engineering application. And so we have seen that across the set of projects where, again, there was some varied application, I think appropriate to the different sets of problems that each project was addressing. And then finally, I think the integration at the latter stages was also more difficult than expected. Again, this is relatively new methodology, and our sort of stewardship of the projects was also new. But in spite of those challenges, I think with some slow initial progress, we actually have been pretty pleased with the results, which have kind of seemed to flood in, I think, at the stage that we're at now. And that was able to support the meeting that we had just in this past September, which was pretty rich. And we were happy to see some cross-project learning, and I think a real desire for that as well. So with that, I think the questions that we wanted to engage you about, let me just open this part of the session to say that, again, you've heard about the status of our appropriations. We're on a CR, I think, as you all know. The budget process for fiscal year 2018, our current fiscal year, is ongoing. But I want to mention that as part of that process, Congress has expressed interest in writing about continued support for this initiative in their deliberations about AHRQ's budget. So I think the questions and your feedback are not really necessarily theoretical for this discussion. They're quite relevant. So we are all ears, and particularly would like your feedback on these questions. Just in general, the value of this approach overall as a contribution. This is just one part of our patient safety program, and certainly the larger national and, in fact, international effort to improve patient safety. We think this is an important a set of projects that are connected very closely to the larger learning health systems conceptual framework. And then even more specifically, we're eager to hear any feedback you might have about opportunities to engage healthcare operation leaders. I think, Bob, some of the comments you made earlier and other NAC members, I think, are relevant to this question, as well as the opportunities to spark public-private partnerships as a result of various findings that are coming out of this set of work. Any suggestions you might have for expansion, as well, modifications or enhancements, and of course, anything else that you might like to comment on.
Great, thanks, Jeff. Don, you had a question.
Yeah, so this kind of comment and question put together, there's a sort of very hygienic, simple question that you can answer at the end, which is, I'm not sure if I understand what a cluster of closely related harms is. That kind of went by pretty quick, and I'm not sure I get that. But more importantly and substantively, and this may be flavored by a couple of projects with IDEO and my presence at a PCAST committee, but it's really easy to talk about prototypes and rapid testing of prototypes and design thinking. In my experience, including experience with at least one of your grantees, they don't really understand what goes into design thinking and that kind of ethnographic inquiry. They get the testing part sometimes, they get a prototype, but they really don't put the human factors and ethnographic inquiry into the design thinking nearly deep enough. And the same would be true of the CONOPS. I mean, that to me looked like any diagram that I see on the gap, the problem, it didn't look at all novel, but I know it is, and I know there's a lot of deep systems engineering thinking behind that. So the question for you is, to what extent do you leverage the shared learning opportunities you have among the grantees to push out the expertise so that they won't continue to use buzzwords? If I hear another innovation laboratory set up or another design thinking program that isn't really steeped in the detail and the methodology, I'm going to go crazy. So AHRQ could play a real leadership role here. All 13 of those grantees ought to know what the hell you're talking about at pretty deep level, and they ought to be then able to articulate what it is that's necessary to move the field. So I think it's a real opportunity for AHRQ in this area, and it can't be done without private partnerships, to tell you the truth. I mean, the thought that a federal agency could actually be the seat of all knowledge on this is nuts. So it's a bold direction for AHRQ, and it will require partnerships.
Okay. Thanks, Don. Your comments are very well taken. In fact, many of the things that you just mentioned, we've thought about, and we really haven't come up with any solutions. We've they're sort of a source of anxiety for us in a way. And so the best I can offer you is that we really, the underlying premise of all of this is that this is a learning opportunity. It's a learning opportunity for AHRQ. It's a learning opportunity for the program officers that are on the project managing it. It's an opportunity for the grantees. It's something new for them. And so I think one of the questions I had for our September meeting was, what is reasonable to expect from this effort? What would we see as a success at the end of their period of performance? What is reasonable? This is new for the grantees. There are some that seem to be following the methodology in very good faith and doing some remarkable things. We talked about the Hellemic grant. That would be one of the examples that I would hold up and there are others too. Certainly the Peter's shop at Hopkins has recognized the value of this for a long term. Alan has had previous AHRQ grants, and so it's nothing new for them, but for other grantees that we awarded grants to, it may be a challenge for them, and they were fairly good at sort of preparing the application and repeating what we asked for in the application, but can they really move beyond the buzzword level and start to actually learn something new from it? And so it's an experiment for us, and it's an experiment for the grantees. We have to be somewhat flexible in terms of what we can expect from it and what we can do through a grant letting mechanism. When I worked in the private sector with engineering firms, the teams that I was placed on were full-time intact teams. It was a team that would work 50, 60, 70 hours a week. We would all know one another very well. We knew one another's likes and dislikes and personal philosophies, and we went out and had beers and understood the family relationships. And so we were certainly a stable, well intact team. I don't think this exists in terms of the type of teams that we see in many health services research applications. I don't think.
Can I make a 60-second comment?
How about a 30-second comment?
30 second. You have a face towards the grantees, but you also have a face towards Congress. And here's where your pitch, I think, has to be a little bit bolder. This is, if you intend to transform the way health services research marries with design thinking and systems engineering, it's got to be a bigger picture. And I've spent enough time with development officers of universities and C-suites to know that you have to put this in a broader framework. Yes, this is preliminary. You're going to get some preliminary data, but ultimately the vision is much bigger, and you've got to be able to relate to what NICHD is doing on Greta the fetal lamb, and all. The pitch has to be a bold future of what health services research and technology and innovation is going to do together. That's my 2 cents in line with what Gopal was asking for.
Thank you, Don. This is Jeff. Just one more quick point to make. As part of looking ahead, actually not only to potential future grants, but the current grants, based on the findings they're producing and what they're discovering. One of the things that I've tried to push among the team is that we really characterize impact as much as possible in a very quantitative way. Actually, in fact, tried to push the grantees a bit on that at that September meeting. We've even considered that, again, as I mentioned, looking ahead to future opportunities and the possibility of including a projected impact statement in their application, as a way to judge and sort of, make decisions about potential applications. One challenge with that is the methodology itself calls for problem analysis in the early phase. So there's discovery in the work itself that somewhat constrains the ability to project impact. This is not the traditional health services research where you design the study, make sure it's appropriately powered, and then you produce your result, and it's fairly close to what you probably predicted. This is, a methodology that's a bit different, a bit more of not a blank slate, but an open, flexible slate than again traditional health services research methodologies. In spite of that, I think there is the opportunity for us to push the envelope a bit more on impact, because it's ultimately what guides our entire patient safety program. That's, I think, one of our strengths is the ability to focus on safety no matter the methodology, the approach, the data that we're using. So we're going to continue to push that and hope to be able to give you more, not only on these current grants, but if we have the opportunity to do more in the future, to let you know how we're thinking about impact with those.
And maybe impact gets built into the discovery phase. Maybe it's premature to do it ahead of time. Chesley.
Okay, I got 3 quick questions. First one, in your mind, are you funding the lab or are you funding a particular problem? And I know that they're both there, but which is the primary driver?
Yeah, so that's a really great question too. These are, it probably gets a little bit too into the weeds, but I'll just say it quickly. We use the P30 grant mechanism, and that's a center-based grant. So that leans us a bit more, in response to your question, to the laboratory itself. Having said that, there are projects associated with it. So it really is a mix, but in recognition of this methodology being somewhat novel, at least in our application, I think we had, we really are kind of right in the middle.
I mean, the way my thinking about it is you're funding a sustainable resource. If these labs are really any good, over time they ought to be centers of excellence where you can bring problems and really in rapid time be able to get to solutions. The second question is, how are you working with industry? It seems like a perfect opportunity for private-public partnership.
Mm-hmm. I think, as Carm said, one example is the patent on, this delivery table.
Yeah.
That's a fairly direct route, I think, to industry, or at least you can see that pathway. Oh, good point. Yeah, so we invited, although not a grantee, we included the Industrial Design Society of America, a representative there. They have a healthcare interest group among their, much broader membership, and I think that is a group that's absolutely aimed towards.
Yeah, the analogy for us at CDC or at NIH or FDA is we have technology transfer. When our labs find something new when they're doing their work, you've got a way to get it to the industry. So. The third question, and then I'll shut up, is this constrained just to patient safety?
So that is the focus. It's because of, I think, the way our funding came in. This is in the patient safety program, patient safety portfolio, as we also call it. So
I'll channel Don. You got to be bold on this, because I mean, when I think about the implications for this in clinical workflow, electronic technology integration in clinical workflow is profound. I mean, this is really fantastic.
I think we don't fail to see that potential. I think it's a matter of, what our board of directors says we should do. And I think it's also in recognition of the fact that a lot of the, a lot of the initial safety and quality work, safety is just, it's frankly easier. I think, the impacts are more compelling. A lot of the problems.
The more you integrate industry, the more they can be your champions.
Yeah.
Because they stand to benefit from this kind of research, I believe.
Yeah, thank you for that input.
So can I just say that was such a model of question succinct, answer succinct. Just saying. Lucy?
Thank you. 2 areas of expansion potentially. So when we were first introduced to talking about AHRQ work earlier this morning, we talked about patient-centeredness. And this seems to be more setting-centric and patient-centric as people move through a continuum of care. And I think, picking 1 or 2 problematic areas like complex chronic illness where people are moving across, and then how that links into the leveraging of technology like asynchronous communications, remote sensing, patient-reported information. I think maybe an interesting way to think about moving forward. And then as I look at who's funded, they're primarily academic medical centers. And so thinking about maybe sort of, this is sort of the alpha test site, and then could you fund beta test sites in other places to demonstrate the utility?
Yeah, that's great. Just a very quick response. I think the particular examples we chose today definitely fit your observation of sort of more setting specific. I think we have kind of the patient centricity is better represented in a few of the others. In particular, I think the outpatient grant.
Yeah, that is better represented in the ambulatory care grants that we referred to. So the patient-centeredness is much more prominent than on the inpatient side.
Sherry.
Yeah, so given that, you know, the incentives actually align with what you're trying to achieve, which is there are disincentives for, you know, unsafe care that already exists. That's important context, right, for how these programs should be taking hold. So there's something that I'm not understanding about why this is hard as far as the sustainability or, you know, the likelihood that a system wouldn't look at this as this is a solution, it's a lifeline. So my question is, how are we learning that from those users, the grantees and others? I think there's something that is a barrier that we're not understanding. It may be, you know, and I think it's important to uncover if we're thinking about how would we sustain this. And one simple question might be, what would keep you from integrating what we learn here into usual care? Like, this is the future. So just it's a
I think, I mean, for me, this might be a simplistic comment, but for me, the grants, or I should say the sets of projects are not constrained by either a very technical sort of nature of a problem or what we might think of as more typical for our patient safety program, where we're looking at how different people within a team interact, what's the set of information they're using. I think it's a broader look across, you know, both types of those and even other types of factors, you know, in the clinical environment. And then furthermore, how they interact with each other, how those different types of factors interact with each other. And so, you know, in some cases, the outputs of these grants are actually maybe a sort of algorithm for how devices interact with each other. So the clinician may not, although they may benefit, you know, from more efficient care, less alarm fatigue, for example, just to be really simple and concrete about it, it may require absolutely nothing for them to do once it's fixed. I mean, the output is really something to industry that is almost invisible to the clinician, although, you know, they may be happier because they're not bothered by, you know, extra alarms. But then I think there are also other things where clinician behavior might change as a result of some of the output. And then again, the synergistic power of the projects overall is, it could be multiple aspects of those, where how a team responds to alarms in addition to, you know, minimizing the, you know, false alarms themselves. Overall, that has, you know, a bigger impact on just addressing one or the other. Does that answer your question? So I think there are a lot of types of findings that don't necessarily fit a homogeneous, uniform receptor site for their application. Some of them are healthcare organizations themselves that would need to apply this. Right. In other cases, industry would be, you know, using the information and making products. And right. I don't know if Alan or Kerm had something else.
Yeah, the other thing to consider, Sherry, is once again, 8 of these projects are just halfway through their period of performance. And so issues of sustainability and what constitutes, I mean, they should have an idea of what success might mean for them. But, you know, one possible measure of success in terms of carrying this forward? Was the progress they were making so satisfactory that their own institutions might want to continue to support it in some meaningful fashion after the project ends, the formal grant ends? Or what are the processes that have been redesigned that actually do find their way into clinical practice? And so then, you know, but the question about how can you expand this on a much broader scale that both Chesley and Don have mentioned, and maybe Gopal can help us on that, because that's the level that I think Gopal is sort of driving us towards. But at the 2-year mark, it may be a little premature in terms of where their thinking is at this moment to actually address that broader problem.
Yeah, I was going to comment that our project 2, where we're developing the smart calculator for insulin dosage, that actually caught the eye of the folks at Hopkins Hospital that stand to be impacted by that, and there are steps underway to actually start potentially integrating a variant of that into their workflow. And I think so that's moving in the direction that you want these things to go. And the ripple effect is that there will be changes to workflow, and some of that culture stuff that takes some time to take hold. One of the ways we try to remedy that is that co-creation part. Is don't just do this off in a corner and then say, boom, here's a solution. It's that involvement of the user, the stakeholder, early and often throughout the process helps that more seamless adoption, dissemination.
Sandy.
Frank, it's not muted, right? Yeah.
Sandy, are you still there? Are you on mute?
Yeah, I'm there.
There you go. Okay.
Okay. So I just a couple thoughts or suggestions. One is I really think this is one. I think this is an important program, and it should be continued and grown. 2 is I definitely would. You guys are learning a lot by having these projects that the projects themselves are not learning, and I really encourage continuing to get the groups together on their own, actually, if you could, and midway through. Sometimes one of the reasons I say this as an investigator, one of the reasons you see such progress just coming together now is because everybody knows they have to come and present something. And it sure grabs your attention. You know, not that any of us ever procrastinate on anything. You know, and I think, but just in the presentation today, there are things that you have noticed, that you have learned about this program, and I think if, you know, to the degree you can, and as the future calls for these, modify the RFP to accommodate that. And 2 things I encourage you to do is, 1, push evolutionary improvement of the model. So people noted some things that were absent with it, human factors, potential financial sustainability or impact. C-suite is going to be interested, but only if the safety problem is overwhelming and they can't ignore it, or it's a combination of safety that is also financially sustainable. And one suggestion I would have, but this is not a strong suggestion, is I look at the places that you've funded. It could be a list of some of the more financially secure academic medical centers in this country. And one way to get the C-suite engaged and invested in it is to make them invest in this, to the degree that this is a lab and not just a research project for one set of problems at an institution. I think it's fair, and there certainly could be, you know, mechanisms for institutions that have fewer resources available to make those, you know, like safety net hospitals and things like that. But to have a tangible matching commitment of some sort, or tangible contribution by the hospital to invest in this type of activity, even on a pilot basis. And while trying to push to find out what the impact is, I would be less concerned with the immediate impact in this stage when we're still learning how to do this better, because you know you can do something that'll have a more something you can be more confident you're going to show an impact, but it's at the expense of taking more risk in designing your study. So those are, you know, just some thoughts. But I think it's a great program and it should be expanded, but expanded by pushing. Not, you know, the things that got funded the first time should not be able to be funded the next cycle. The standards should be higher of what you're looking for, based on what you've learned and what others have said about where there are opportunities for improvement.
Jen.
I guess mine is more of a comment, but I was heartened to see there was some primary care and outpatient ambulatory care areas where you're working on patient safety. But I was also then thinking back to the beginning of our day today when Gopal gave the example of how we have such uncoordinated systems across social services and healthcare, and Jose reminded us about social determinants of health. And so I would challenge us to think about safety outside of hospitals, outside of healthcare. How do we integrate and coordinate information and do a better job of keeping people safe and improving their health? And so if we can push the boundaries of the patient safety portfolio to person safety and health, I think there could be some really creative and desperately needed help from these human factors engineers and other engineers to how do we maybe not create another bell and whistle, but how do we better coordinate, integrate, communicate with our neighbors and our friends in these other organizations and break down those silos. Again, getting back to the silo theme that we talked about again. So maybe we can be a little more creative if there is another call to think about safety beyond the ICU setting.
Even though it wasn't a question. It's a push and an initiative that we have been on for probably 3 to 4 or more years. That is, we've labeled it extending patient safety to all settings of care. I think you can, obviously the patient's in there. And again, as Kerm said, we were very pleased to have at least a few here. I think the topic of diagnostic error, diagnostic safety, that's automatically going to pull us even more into other settings. And
I'm pushing us even beyond that. I'm pushing us out of healthcare because I really need systems to identify and address social determinants of health in the patients and the people that I work with in a primary care setting. And so, that much of that information in those systems exist outside of the healthcare arena. And so helping to integrate and do a better job of coordinating those systems. So it is pushing the thinking even beyond.
No, you're absolutely right. That is.
It's let's get upstream and further upstream so that we're not so worried about the downstream errors that could be preventable if we were upstream helping to prevent them.
Thank you for the clarification.
Mary?
So maybe just dipping your toes into that rather than taking on all of the world, there's a pretty substantial body of knowledge that says that the 3 trillion to 5 trillion that we're going to get to by 2025 is what happens when people leave the hospital and go to the next site of care. So it's not a setting, but it is the huge cluster of problems that happen, the gaps in services that happen that contribute to these avoidable high cost use of services. So I think that could be a really central part of your work. And so the question is, in the problem-solving phase that you're describing, how much of available evidence, because you describe it as, you know, this huge effort to look within, but how much of the available evidence of people that have followed the same set of challenges across multiple systems for thousands of patients are influencing the problem, you know, accelerating, I should say, the problem phase, problem identification phase?
So if I'm understanding your question right, it's sort of how much original work actually happens and how much are these projects drawing from what's already available? Is that so? Yeah, and I think that's a tension that I've kind of was touching on with respect to the question about, or the point I made about impact, and that is that, you know, we can if we're obviously Alan and Kerm are the experts in this methodology, but I think, you know, perfectly applied, you sort of do come with a relatively blank slate, you know, to the problem. I think that we've adapted this appropriately to, I mean, we obviously have to have applications to respond to and to make a decision about funding. So I think we are requiring a higher bar with, some pre-work, some, at least a prediction about what they're going to find when they do their problem analysis. So I don't think it's, in my view at least, completely pure, but I think that's an appropriate adaptation of this methodology to the use that that we have for, in patient safety. Alan or Carm?
Yeah, with ambulatory care, I think the problem analysis phase is magnified, the importance of it. There you are starting with a blank slate. Most engineering efforts are re-engineering efforts. There's a system already in place. Its shortcomings have become known, and so now with new technology that's occurred in the last 10 years, that needs to be, they want to take advantage of that, and so that gets incorporated with the existing design to realize new capabilities and to avoid inefficiencies that the previous system had and the vulnerabilities for safety. And so, but with ambulatory care and the social determinants of health and the things that Jen was referring to in terms of even moving beyond the health system into these work-life social determinants, that is a blank slate. Yeah, I'm afraid.
Okay, well, that was terrific, and I think you heard a lot of enthusiasm both for the work and then a lot of enthusiasm to push way beyond what you're doing. So that's always a good sign. So anyway, thank you, Jeff, Kerm, and Alan, for spending some time with us today. And I think we look forward to hearing more as the program evolves. And yeah, good. So as I understand it, we have one public comment. Peggy, do you want to come introduce yourself and find, oh, right there. Yeah. It's like, where did it go?
Thank you so much. I am Peggy Benzer. I'm with the Alliance for Quality Improvement and Patient Safety, and I will be very quick because I know that I'm the very last presentation and it's been a long day and interesting and fascinating and wonderful day, however. I'm hoping to contribute to that information and knowledge. We represent the patient safety organizations and all of their members. We are an AHRQ program, but we're a much different AHRQ program. We're actually a private sector program with some oversight by AHRQ. And we are an incubator of innovation. The Act Congress intended for us to break the silos. So what they did is they gave us a baseline of peer review protections for all licensed providers so that we can all talk to each other and share information and connect the healthcare continuum. It's taken us a while to figure out how to do that, but we're getting to the point where we're implementing programs that really do take a systems analysis. We're following patients from the moment, the first point of care, EMS, and taking them to the emergency room. We're connecting EMS with emergency rooms to do gap analysis. How can we communicate better? Because the silos are really intense. EMS and long-term care, for example, don't have meaningful use. They have separate EMR systems and separate care systems regulated under different agencies. And so there isn't a lot of connection, and our organizations work together to give them a connection so that we can do gap analysis. In hospital systems, we connect physicians together and get them in a room to talk to each other. So we have a lot of programs with surgeons, particularly because their judgment can be life and death to a patient. And so we have what we call convenings, where surgeons get together and talk about their problems and systems of care. We find that surgeons can be great surgeons in one care system and have not such great outcomes in others. And so we have PSOs who are researching and looking at that. Why, we know we have a good physician, So why can their outcomes be different in a different system and different environment? So we have other systems root cause analysis. Systems analysis is an RCA squared type of program that we do where the hospital system can bring in anyone, all of their clinical contractors, long-term care, primary care, to really, and also EMR vendors, because we're finding with all the patient harm that we're seeing, there's always an EMR or a medical device contribution. It may be a large contribution, it may be a small one, but what we're trying to do is bring everyone together so that we don't change our reaction and our process as a human process to the system. We want to change the system so that we create a learning system with our physicians and other healthcare providers, but if we can change the system, then it will never happen again, rather than trying to teach everyone so that it won't happen over and over and over again in every single health system across the country. We're bringing new programs. Primary care is really desperate for quality programs, and we're bringing modified peer review programs. Now we have hospitalists, so they're getting farther and farther away from the hospital setting, so we can bring them into the hospital setting as well to get greater information and greater care. So these are just some of the examples of the programs that we're doing. Really, we are incubators of innovative programs. We get no government funding, and that was design of Congress. We solve each provider's different problems, and so we have to provide value. And we've been through a lot of the questions that you're going through now with your learning health systems. What's the ROI? And so we've had to learn the hard way how to develop programs to give the ROI. And we've learned by surveying, and again, we can do confidential surveying, so we survey CEOs. What are your biggest problems? What do you see? And generally from the CEO crowd, we find that it's the issue that's costing them the most money, that they don't understand why their providers can't fix it or do a better job. When we go to CMOs, the question there is what's keeping them up at night where they really think they can do a better job. So it's a much different analysis, and our programs that we develop are much different. When we get down to the nursing staff and other staff, it's more about the day-to-day opportunities that they'd like to have better efficiency, better contact, better closeness to patient. But what we can do is bring together all of these different healthcare providers, whether it's within a health system or whether it's bringing, and what our PSOs do is bring together all providers that are unaffiliated from all different types of health systems and raise the problem. Or what's even more interesting that we're doing is bringing a case and a case study and doing a group root cause analysis, where what we're seeing is our hospitals do a great job with root cause analysis with the protections that they have, and it's usually a limited group. But when we bring in all the expertise from all of the different health systems, the root cause analysis is so much richer, and we have so many more contributing factors that we're able to then fix the systems throughout the healthcare continuum and not just in one hospital system. So this is the kind of learning that we're doing. We're going through growing pains, but I think that we're now focusing more on connecting the healthcare continuum, sharing information, and really rapid process improvement. We find that when we have our convening sessions, people can bring learnings home and implement them the next day, because it's just that rapid process improvement where, you know, look, we've been doing it this way, we don't see the problem that you're seeing anymore. So that's what we do, and so I'm hoping to come to your advisory committee meetings and bring a little bit more about what our patient safety organizations are doing. We'd love to work with you on the learning health system because we can break a lot of barriers that the health care community may not be communicating to you that it is a barrier. So thank you so much, and we'd love to be the private side of the public-private partnership.
Thanks, Peggy. Okay, so again, that's all right. Oh, sorry. Oh, yeah.
If I could get your indulgence for a few minutes. I would like to acknowledge your term as chairman, Beth, chairwoman, for the last 3 years, and a thanks from all of us at AHRQ for your leadership. You arrived as chair shortly before I started at AHRQ, and I know that we have seen quite a bit of transition over that time. We're now on the third director since you've been here in 3 years.
Is that right?
Yes. Yes.
It's me, it's true. Oh my goodness.
Maybe it's me, maybe it's me. So, and you've been a really steady presence, and as always, your insights and ability to kind of lead the discussion in a productive manner have been very helpful. So on behalf of everybody, I want to say thank you so much for your service. We're really going to miss you.
Thanks. Well, it's been a real privilege. I have to say that when Rick, our director number 1, called me, I was actually sort of surprised to be asked to step in as chair without ever having been on a committee. I'd never done that before, but I kind of like it going straight to the top. So anyway, and I've enjoyed the opportunity to spend more time to get to know and get to see all the things that AHRQ has been doing, and we were talking about this a bit at lunch, just the evolution of the agency and the time that I've been involved with the advisory council. I just think you guys are doing great stuff, and I always thought that, but I think you're doing an even better job of making that clearer to those who didn't know you and love you to begin with. So anyway, so thank you very much. Oh, sorry.
Well, I would like to add to that. Many thanks to you as well, Beth, once again. And as you, I hope the fact that you are completing your term as the chair does not mean that you're going to be going away, because we'll be coming to you for more help and guidance. And then we are fortunate. I had put in a call and asked Don Goldman if he'll be willing to be the chair, and he's kindly agreed to do that. So I would urge ladies and gentlemen to welcome Don with a round of big applause. He'll be the new chair starting next meeting, correct? So Don, are you still there?
Yes, I am.
Yes, sir. Thank you so much.
I think you
welcome.
I hope that no one regrets it. You see that I'm a rather feisty member of the council already, but in the role of chair, I will try and moderate myself a little bit and be a facilitator.
Well, it'll be good if you keep us on our toes. You want to have more? You have any more comments before I?
I just wanted to thank the other people who are retiring. Did you have something else you wanted to? Oh, okay. So just once again, Jen DeVoe, Kevin Grumbach, and Mary Naylor, who went dashing out to catch a cab. Thanks again for your service. We will have an opportunity now that we've changed chairs to see if it was the chair or some other factor in the environment. It's a natural experiment. We'll see if that does anything for stability. So, and then I want to thank the NAC members, Gopal, Sharon, and then all of the presenters we had today, Jenny, Pam, Jamie, Bridget, David, Ed, Herb, Tess, Jim, Harry, Aaron, Jeff, another Jeff, Kerm, and Alan for the presentations, the AHRQ staff who were here, and those who attended in person and those who watched on the webcast. I'm sort of cognizant of the time that a lot of people are trying to run out. What we usually do at this point is to go around and ask if anybody has any further comments or suggestions for the next meeting. So I will sort of say, as people may need to peel off, but if anyone wanted to put some thoughts in. Bob?
Thank you. My last thought is perhaps we could think about what the big challenge that AHRQ could articulate for the external constituencies. So for instance, the NIH has this precision medicine initiative. gets a lot of advertising, it gets money. People think, well, we're going to be able to really more precisely treat people based on all the genetics and the interior makeup. You could do something similar to that with the data you already have, sort of a precision health system program where you're trying to learn about how the health system, so their target is the patient and all the variability of the patient, and your target is the health system and all the variability in the health system. But it might get to that elevator speech. It might get to being able to what differentiates you. No, the NIH is not about that entirely, but there's a lot of buzz generated by that. And you're not just about this piece, but you might be able to generate a buzz that would help differentiate you. So whatever the big challenge might be, it could be that at the next time we could talk about what those things are or what you think you've come up with.
Terrific idea. That'll be great.
Any other parting thoughts or comments? Alice?
I second that idea, except I wouldn't want to use the word precision, because I think then you might get a Me Too kind of, I think you have to really think about language and communication and your brand and your differentiation, as we talked about earlier, because that does language and communication does matter. It has to be memorable.
Okay then. Well,
Yeah, this is Sandy. Sandy, two things. One is we actually had a perspective in the New England Journal a couple months ago about this topic, and I do think if it's done right, what our argument was that basically that there needs to be health services research policy delivery corresponding component to precision medicine. Congress in the country is investing an enormous amount of money in this. Their attitude sort of is you build it, they will come. You get the scientific advances, it's going to be pretty much ordained what to do with them. We all know that that's not the case. And I think that that is a potential future opportunity for AHRQ. The other one that I would note is a concern of mine has to do with this country is moving very rapidly to a significant change in how we are paying people. With dramatically increased risks, the level of risk taken on by providers and financial models that are really shifting from a pay for volume to a capitated payment of some sort, an at-risk payment. And I think there are a lot of potential threats as well as opportunities to safety and quality in this that we need to start thinking about differently. So those are sort of what I think are two very different but important things to try to get ahead of. The changes in reimbursement will happen over the next 5 to 10 years, but they're happening faster than I would have thought they had. And I think now's the time for a place like AHRQ to start thinking about what does this require or demand of us if we're going to maintain and improve safety and quality. And I think this is my last meeting too. I want to tell you first, you are a very telegenic bunch. And second of all, it's been a real pleasure to serve on this, on the advisory council. And I think the organization has really come through a very tough time, and I'm really beginning now to feel optimistic about it going forward.
Thanks, Sandy.
Sandy, thank you, but you're not off the hook. We'll be coming back to you. You've just given us a couple more interesting ideas, so you'll hear from me.
Oh, I thought you were the one who was now off the hook with me.
Okay, with that, I think I will call the meeting adjourned. Those of you not in the room can't see that it's adjourning itself, so I think I'll actually call it before it completely disappears. Anyway, thanks everyone. Bye.
Thank you, Glenn. Beth.
Bye.